I've been in the medical business actively virtually every day, except for time off for this or whatever, for 44 years. And I practice a very different form of medicine. Now, it's difficult for a physician to get involved in this kind of medicine. I have not had a detail man from a pharmaceutical company come into Whitaker Wellness, and there's 6 docs there, for the last 20 years. Now, I don't know if that's good or bad, but they know that we really don't involve ourselves a great deal in prescription pharmaceuticals, particularly for the diseases with which we treat, which is heart disease and diabetes. So I'm going to talk about 3 of the conditions: diabetes first, heart disease, and cancer. Those 3. I have about an hour, so I hope to spend about 20 minutes on each one. Now, I read somewhere that you can tell the truth about anything in 2 minutes. So we have about an hour. So 2 minutes into 60 minutes is 30. I'm going to see if I can give you 30 1 to 2 sentences of truth that you can believe it or not, but you can't, it's just true. So I will program that, and I will let you know. I'm going to make a couple of statements. I'll make statements as we go along, truth statement. I have no idea how many of these statements are going to come up because I've never done this before. Okay, let's start with diabetes. We're going to talk about the paradigm of diabetes. First, what does diabetes mean? I don't want you to take the time, but write down what you think diabetes means. The word, where does it come from? Where was it derived? What does it mean? And I'll go right to the definition. Truth number 1. Diabetes means excessive urination. That it comes from the Greek word meaning passing through. There are 2 medical forms of diabetes. There's diabetes mellitus, truth number 2, which is excessive urination of mellitus sweet. And there's diabetes insipidus, truth number 3, another truth, which is excessive urination because of an abnormality in the antidiuretic hormone from the pituitary. These individuals cannot concentrate urine, so they drink literally a gallon to 2 gallons of water a day, and they are constantly in the bathroom. But diabetes means excessive urination. Next question or thought. Why do diabetics that we know that have these elevated sugar problems, why do they have excessive urination? Anybody know? And this is crucial. Truth number 3. Excessive urination from diabetes mellitus is because the elevated blood sugar level becomes a diuretic. It becomes what we call an osmotic diuretic. Normally, the blood sugar level will range from, say, 70 to 140, 70 or 90 to 150. When you have blood sugar swings of this level, there's no sugar in the urine ever, because the kidney knows that a glucose molecule is the number 1 priority to save. Many people think that the kidney is trying to get rid of extra sugar and throwing it into the urine. Truth number whatever, this other thing. No, the kidney's not trying to do anything but save all the sugar it can, but so much sugar and so much fluid is come on through the kidney, it can't. And so it's lost. Then you have sugar in the urine. You begin to have sugar in the urine at about 170, 175. You have no sugar with glucose is lower. Okay, now if this glucose is what we call an osmotic diuretic, this is another truth. Now, an osmotic diuretic is a diuretic because the particles in the blood are creating an osmotic pressure. For instance, if you go to the Great Salt Lake or fresh water, the water looks exactly the same. But the Great Salt Lake has a very powerful osmotic power because of all the salt that is dissolved in the water, correct? Now, what would happen if you take a goldfish out of a freshwater pond and drop it into the Great Salt Lake? It dies almost instantly because the osmotic pressure in the Great Salt Lake literally sucks all the fluid out of the fish. So there are two forms of diuretics. There's an osmotic diuretic, and then there are other forms which block kidney tubules or whatever, Lasix and things of that nature that do it differently. But an osmotic diuretic causes the kidney to fail in its ability to save what it is trying to save. Now, it obviously is not saving the glucose. And that is the number one priority of the kidney, is to save glucose. Well, what else is going out? This flood of fluid going out of the body and into the urine is virtually all of the water-soluble vitamins. Diabetes is a nutritional wasting disease. It is a nutritional wasting disease that you have to compensate for. Otherwise, you're going to be chronically low in all water-soluble nutrients. Now, there are two forms of diabetes, correct? Two forms, all right? There's adult onset or non-insulin dependent, and there's insulin dependent. They are entirely different. They are diametrically opposite. In the juvenile diabetic, the pancreas has been destroyed, rather islet cells have been destroyed. There's some very interesting studies on how Finland is now experiencing an epidemic of juvenile diabetes, whereas back in the 60s and early 70s, their incidence of juvenile diabetes was about 10 to 15 per 10,000. Today in Finland, their juvenile diabetics are around 100 per 10,000. Why this tremendous increase? Does anybody know this story? Vitamin D. It's vitamin D. Vitamin D deficiency. Back in the 60s, children were getting the recommended daily dose of vitamin D of about 2,000 units. Then they were at about 15 per 10,000, and then back in the 70s and early 80s, it was reduced without explanation to 1,000. Big spike. It went up to 35 to 40 per 10,000. Then without any reason, vitamin D recommendations for children were reduced to 400 microunits a day. And now they're having an epidemic of diabetes. And so if you look at the epidemic of diabetes in Finland, where they have a very sophisticated medical support group and very sophisticated taking records, they have an epidemic of juvenile diabetes. The vitamin D alters many aspects of the immune system. When the vitamin D is absent, there's leakage into the islet cells of the pancreas. The immune system then attacks the islet cells, destroys them, and you have juvenile diabetes. The incidence of juvenile diabetes in Cuba is 2 per 10,000. And we see these epidemics of problems related to vitamin D, of which juvenile diabetes is only one. So, juvenile diabetes is an insulin deficiency problem. The 90% to 95% of the diabetics in this country don't have juvenile. They have non-insulin dependent adult onset diabetes. That is caused by obesity. It should actually be called diabesity, which is the form of diabetes that they have. Now, if you look at the 4 symptoms, this is another truth. If you look at the 4 symptoms of diabetes, they are excessive urination, excessive water drinking, dipsia, polyuria, polyphagia, excessive eating, and weight loss. Those are the 4 symptoms of juvenile onset diabetes. We used to see them at Grady Hospital. They'd come in having a history of having lost 27 pounds in a month. They would be dehydrated, Kussmaul respirations, highly acidotic, very low CO2 levels. We'd have to start blood fluid on them, give them insulin IV, and voila, we stopped the process. So more or less cure the problem. And now they take insulin. That's the juvenile. The obesity, they produce excessive amounts of insulin. You know, we get hung up in this idea that diabetes has something to do with an insulin lack. Well, the type 2 diabetic has 2 to 3 times the amount of insulin produced as does a normal, active, thin, and healthy individual. But that insulin doesn't work. And now we have the concept of insulin resistance. And insulin resistance is where the insulin does not work to open up the door of the cell so that the glucose can go in. And that is associated with diabetes. Think of insulin as a key, and think of the cell doorway as the door that you need to open to have glucose and amino acids go in, and think of those keyholes plugged up with fat. So that's insulin resistance. So you can't really eliminate or gain ground on type 2 diabetes unless you gain ground on the obesity. And when you gain ground on the obesity, the type 2 diabetes goes away. So how do we treat type 2 diabetes? Well, we treat type 2 diabetes the same way we treat type 1, with medications and also with insulin. Now, in 1971, there was a study on does insulin or the pills, they were actually looking at the pills. Does the pills and or insulin, but it's concentrated on the pill, do the pills reduce the complications of diabetes? You see, people with type 2 do not die from diabetes. What do they die from? Heart attacks. Number 1 cause of death in a type 2 diabetic is heart attack. That is the primary complication that you're trying to avoid. So they don't die from diabetes. People with type 1 can die from diabetes unless you give them insulin. But type 2 is different. Their blood sugars may go to 300 to 400, but that's it. You don't die with blood sugar levels that high. You die from complications. So they did this big university study back in the 60s and 70s, and they had a double-blind placebo control of you either taking placebos or you're taking the first cousin of metformin, which was DBI, and the first cousin of glyburide, which was Oronase. So they're taking DBI and Oronase. The study was to run 12 years. And at 7 or 8 years into the study, there was already this escalating death in one of the groups. And since it was double-blind and placebo-controlled, they didn't know which group it was. But what they knew is that they had to stop the study because they knew that the differential between death in one group was so much higher and increasing than in the other group that it would have been unethical to continue the study on for the next 4 to 5 years. So they broke the code, fully expecting what? What did they expect to find? That the high death rate was in the placebo group, right? What did you think they found? The high death rate was in the pill group. Both DBI and Oronase increase the death rate from cardiovascular disease by up to 300%. Now, 300%, is that a lot or a little? Well, let's look at it. It basically would have increased the death rate of type 2 diabetics by 1 death per 100 of diabetic patients being treated with the pills. Whereas being treated with the pills, they'd have had 2 deaths per 100. If they didn't have the pills, it'd have been 1 death per 100. No physician would ever pick that up, that 1 of his or 3 of his 500 diabetic patients died of a heart attack, whereas if he wasn't using the pills, only 2 of them or 1 of them would have died from a heart attack, right? But you throw in 30 million people, now you're looking at tens of thousands of deaths, not associated with, but caused by the diabetic pills. So there's a causative effect. And then they even found out the causative effect. So what did we do? Well, we took DBI off the market. It then came back in the early 90s as metformin or glucophage. So now we have DBI on the market. Then we took Oronase and we put a strongly worded warning on that. What difference does that make? You know, I find it so interesting that when they find that these, like these things with the Lipitor causes liver toxicity. So what do? They want to bring more people in to get liver tests instead of stopping the drug. I guess they want to follow the toxicity as opposed to eliminating the toxicity. So it was the same thing with the Oronase. So they put a warning on that, and the warning still exists for almost all of the diabetic pills. That warning reads, these pills have been shown to increase heart attack and heart death compared to those not taking the pills. So when you're taking these pills, you're taking something that warns you that it increases the very side effect you want the most to avoid, and that is death. It says so right on the label. Crazy. Well, the problem with the approach to this for diabetics is, and I can understand this, you know, you're a conventional doc. What do you do if you can't script them? You know, when I was an intern at Grady Hospital in Atlanta, Georgia, that's 1970, I was known as a high producer because I could see more people in the general admitting clinic or the outpatient clinic where interns and residents and chief residents, we all saw a whole bunch of people. I was known as a fast, productive worker. I was fast. You know why I was fast? I took my prescription pad and I wrote out all of the prescriptions that I know I was going to give, the dosage, the amount, the refills, the number, and I signed, and all I needed was the patient name. And I was fast because I didn't spend all that time writing all that stuff while all my other guys, you know, didn't figure out how to be efficient in that clinic. So here's your diabetic pill, here's your phenobarbital for your high blood pressure, here's your DBI, you know, so that is what physicians do today for type 2 diabetes. Truth. The treatment of type 2 diabetes today is far worse than no treatment at all. And it causes early and untimely death. Now, what are the other things of how can you treat this condition? Well, you obviously have to do something with the patient's weight. And John Davidson, and it's interesting that this has kind of come full circle because I knew John Davison. He was the head of the diabetic department at Emory University and at Grady Hospital, where I interned. And I remember sitting in conference with him. And I had left then before this study was published. But John Davison read this study, and he said, I cannot ethically give these pills to any diabetic because it increases the very thing we are trying to prevent. He was the only university-based professor of medicine, MD, PhD, who stopped the use of all diabetic pills at Emory University and Grady Hospital, which had 18,000 patients in their follow-up group, no pills. Now, so he stops the pill. What does his residents do? You see, you take away the pills, you go to a doctor, he says, well, now you got to exercise more, you got to eat, etc. I said, well, don't you, well, what else? Just exercise more and eat. Well, I mean, what's the patient going to think? You see, doctors are caught. Even if they know the pills are bad, it's like they can't have anything else to do. And if they don't have anything else to do, then the patient's going to say, oh my God, why am I wasting your time with you? So, and many times, it's worse. Many times the doctor thinks the pills are good. Now, I don't know what's wrong with them, but there's a couple of connections up in the cerebellum, in the cerebrum, that don't fire anymore in those doctors. Because they actually think they're doing good by giving them more and more pills and insulin. So, the doctor can't do that. So what did John Williams do? Now I'm going to jump ahead and then I'm going to jump back. Well, John Davison, heavy-set guy, 85 pounds overweight, swollen feet, beginning of a diabetic ulcer, blood sugar levels 300, A1C 13, high blood pressure, can't walk. What? Okay, yeah, great. Can't walk. What did he do? He said, follow me. We're going to Grady Hospital. You're checking into room 204, and you're not going to have anything to eat for 7 days. You're going to walk around the hospital. You might want to get a piece of tape to hook up your gown so your butt doesn't stick out. But you're not going to have anything to eat for 7 days. Water fast. That's what a doctor can do. And he has charts of these people who were failing all kinds of dietary directions that lost 9 to 10 pounds in 7 days. Most of it is is water and fluid, etc. But fasting reboots the computer. We are addicted to the food that we eat. Fasting reboots it. And all of a sudden, what you could not possibly do, you now can do. I have known this since 1980. I wrote the book Reversing Diabetes in 1985, revised it this year, several years ago. And I've known that John Davison was doing fasting. John Davison, by the way, retired, left Grady Memorial Hospital, left Emory in 1992. Within 2 months, they had every single drug back in the formulary. He also told his docs, you cannot use insulin in any patient who's not optimal weight. Think about that. I mean, as I look around here, I could probably pick out 4 or 5 people with type 2 diabetes possibly taking insulin. When I go to orientation of patients that come into Whitaker Wellness, and there might be 30, 35 people there, I ask, how many of you have diabetes? Now, because we attract diabetic and heart patients. And maybe 20 of them will raise your hand. How many of you have type 2? Same 20, raise your hand. How many of you are taking insulin? And they're all heavy. About 17 will raise their hand. How many are taking both? 15 will raise insulin and drugs. They're all heavy. So then those that are taking insulin, I don't ask, have you gained weight on insulin? I already know the answer to that question. I simply say, how much weight have you gained since insulin? And how much weight have you gained since insulin? And when we do that, we find an average weight gain of about 20 to 45 pounds, average, depending upon the groups. I had a patient in the mid-1980s who comes in, he was diabetic, pills didn't work, started him on insulin, 10 units. And every year he gained 10 pounds. What happens when this type of diabetic gains weight? Blood sugar goes up, right? So then what does that stimulate the doctor to do? More insulin. So he gained 10 pounds, increases insulin dose 10 units over a 10-year period. Do the math. He gained 100 pounds, and when I saw him, he was taking 100 units of insulin. So we stop his insulin that day. Take his bottle, drop it in the trash, take his syringes, drop them in the trash, and they freak. Because they've been taking this insulin for 10 years. But he's also gained 100 pounds. Well, it took him 8 years to lose that 100 pounds, and it took him, and he never went back on insulin or drugs again, which is the way it should be. Now, there is no reason for a heavy type 2 diabetic to ever take insulin, because they will just gain weight. The biggest I've ever seen was I was speaking to a group of hospital administrators. Now, I'm not your general fare for hospital administrators. I have no idea why I was invited. And I don't think I'll be invited back, even though I try to keep it, in a civil and intellectual frame. I was a little more cautious with my choice of words. But I did tell the story about the weight gain in the insulin. One of the biggest human beings I've ever seen in my life came up after the program and said, well, I'm very interested in this insulin and this weight gain, because I've been taking insulin, I've gained weight. So I looked at him, it looked like, seen the movie The Blind Side? It looked like Michael, the big guy. I said, well, how much weight have you gained? He said, 170 pounds. That's a whole person. That's a whole adult person. Now, I've got to ask you to get your brain around this. How can a physician, who first is a human being, sit at his desk and over years' time monitor 170 pounds of weight gain brought on entirely by his increasing dosages of insulin? Somebody has got to clue me in on what happens to the thought processes when that occurs. And the reason is, well, his blood sugar's too high. Okay, for 35 years, we have been treating diabetics with good diet and exercise, etc. We didn't use John Davidson's fasting method. I was scared of it until I personally gained 25 pounds. You know how I gained 25 pounds, 30 pounds? I didn't do what I tell everybody else to do. I was America's wellness doctor, and I was pretty sick. Blood pressure was up. And I said, I got to do something about this. I used to eat with my patients, and then we got bigger, and then I stopped eating with them, and then I started eating at restaurants. And so I was not doing what I'm telling people to do, and it was obvious. So about 6 weeks ago, Connie and I went up to True North, which is a group of doctors and healthcare professionals who do fasting. And we fasted for 6 days. In 6 days, I lost 21 pounds. It was like I was up there and they stuck a needle in me and a bunch of salt water came out. But it reset the computer. Now I can much more easily adjust to healthier lifestyle. So we now have started that at Whitaker Wellness. I was afraid of it because, unconventional docs are already under the gun. And I was afraid, when you're fasting people, But, when you look at fasting, it's tens of thousands of years old. And there are people who fast for religious reasons. There are people who fast for medical reasons. And as far as diabetes, so now if I have a heavy diabetic come into Whitaker Wellness, I'm going to say, look, I know you're going to be resistant to this. I know you're going to look upon it as an anathema. I know you're not going to want to do that. But the shortest distance between 2 points is for you to check in. You take this water bottle, you put a little ribose in it, you fill it up 4 times, and you drink all of that water, and you don't eat for this week. And they say, and when I think about it, and you look at the complications of this particular disease, I'd rather have cancer than rampant diabetes. Because rampant diabetes kills you. But before it kills you, body parts fall off. Your eyes, your kidneys, your legs, heart attacks. You can't feel anything. And all of this is occurring because of this osmotic loss of all the nutrients, because of the insulin resistance. And I understand it. I resisted doing this myself for 20 years. To find I said, all right, I got to do something here. So I went up there and I started fasting. So now we have a fasting program at Whitaker Wellness. Truth. The most powerful and predictably beneficial result for type 2 obesity-related diabetes is fasting. There are other things you can do, but that starts the pathway back to health.